that sometimes when this pressure is relieved, this area here re-expands, and sometimes if it re-expands quickly enough, you can get what we call intraparenchymal hemorrhages, meaning blood can accumulate inside the brain substance itself. Again, what's the number on that? I'm not sure. It's a small percentage, but it's not zero, and that's the reason why I bring it up.
Well, I know.
Let's see what we
Now,
think.
with the information I have for you so far, his lab value, so his INR at the outside hospital is 1.7, which is not normal. It's 'cause
What's
he's
the
on
INR?
INR is a measurement of coagulation, the blood coagulation.
Oh.
It's just a number we follow, and we
Okay.
slap the value to it. The a normal number is anything below 1.3. So what we'll probably do is give him some special. We'll basically replace some of his coagulation factors to get that number below 1.3 if we were to do something about it. So that's number one. Number two, his neurologic exam seems like he's at his baseline in terms of he may not be moving around like he had been. He may not be as verbal quite as much. But at least in terms of a neurologic exam that we can reproduce, he's pretty good. In other words, he's symmetric with both sides. It doesn't have a facial droop. In other words, there aren't things that I can say, look, this thing is probably causing trouble, weakness or something like that. Now, globally, it's probably affecting him. It's probably affecting his ability to form speech, and that's because it's on the left side. 93 to 99% of us are dominant on the left side. Especially if you're right-handed, you're dominant on the left side in terms of your speech production. And so that's probably accounts for some of his difficulty. The falls, that's probably why he may be falling to the right side, because of course the left side of the brain controls the right side of the body and vice versa. And the one thing that you'll say is, well, Doc, I think you have your right and your left mixed up. Well, the right is the left and the left is the right when we look at pictures in terms of radiographs. And the reason why is because they take the pictures from the feet up. So if you imagine kind
I
of
see,
the top of the head is here and
Yeah.
the feet are laying out this way.
Right.
So that's everything's a little
Okay.
complicated. So that's why I say, all things considered, there's no urgency or emergency. In other words, it's not something that has to be done right away. But in situations like this, we try to prepare for things and try to prepare, at least get our ducks in a row to be aggressive if we have to, if something changed. Does that make sense? In other words, it's not that we think that there's something that needs to be done right away. It's that if you would consider surgery for him, we wanted to be aggressive about getting him set up for it, if that makes sense.
So if you do nothing, he's not going to get better than he is now.
Probably not.
Yeah,
Probably not.
and it could get worse.
Correct.
Will probably get worse.
Hard to say, but it probably will.
Well,
I mean,
yeah,
in
if
other
there's
words,
new blood
that
coming in
new blood
already,
has-
it's going to turn into
Yeah, we
old
don't know if
blood
it's going
and-
to change. We're going to get a repeat head CT, of course. We reevaluate these things. He's going to go down soon to get that, and so we'll know more once that comes back if there's any changes. But yeah, there's the tendency for these things is that they do accumulate slowly over time, and that's probably what's gone on up to now.
So what are the success things? That, I mean, successfully for a person his age. I mean, I know you've told me the risks,
Yeah.
but I want to know
The upside.
the upside.
She wants to hear that
Well,
he's going to do the jive
sure.
as soon as he gets out.
So
Yeah.
the surgery itself is fairly well tolerated. In terms of a scalp incision is not very painful. It's not fun.
Yeah.
It's well tolerated.
Right.
It's not something you do on a Saturday night for fun. But,
Right.
the craniotomy itself doesn't hurt. In other words, when we take the bone off, it's not something that hurts.
Okay.
Um,
He's sedated. And
oh yeah,
just
yeah.
doesn't
No, if
hurt
we do any
anything.
kind of surgery that's under general anesthesia, the patient would be intubated and sedated
Okay.
completely.
Okay.
And at the time of surgery, like I said, we kind of make a game time decision most times about whether or not the bone should go back on. Now, what do I mean by that? Well, what I mean by that is if there's an indication that we have at the time of surgery that there's some active oozing that we can't control with those membranes I was telling you about, sometimes we elect to leave that bone off
For.
a period of time. It's hard to say, sometimes
Okay.
a month, sometimes 3 months. And
Okay.
we wait for things to calm down. We get repeat Head CTs too.
What does he wear in the
Does he wear a
meantime?
helmet?
No, you can wear a helmet sometimes,
Oh.
but usually you don't need anything. But we can get helmets.
Is there a dressing some kind? How does?
We
Is
close
it
the
open?
wound. No, we close
Oh.
the wound. The scalp
His
is
brain is not open
The
to
skin
the
is
sun.
closed. The skin is closed
Oh,
open.
okay, thank you.
Get a brain burn from
It's the
it.
first time I've heard.
Of course.
I've never heard anything about this before.
No, I imagine you've never been through this.
No, I never have. Okay, so all right, so the skin is closed.
Yes, ma'am.
Shut up. and then what? Then you're just watching him.
Then what
he
we do is
comes
we-
every.
Well, yeah. So what we do is we get him
Monitor
through an
him,
acute
huh?
process in the hospital, and that may be. I mean, it's hard to say. It's hard to predict how many days, in the hospital, that kind of thing. And then we go from there. If he would benefit from rehab, that's a possibility. If he would go home, that's another possibility. In other words, we don't know those things until we cross that bridge.
Okay. What do you recommend?
Well, that's why at this point, what I wanted to do is sort of have an open dialogue about it.
Yeah.
Now, if you were of the feeling that no, he never wanted any surgery, that's just the way it is, and that's the way he wanted it, that's one thing.
Mm-hmm.
If you said, of course we want everything done, that's another thing. But then, of course, if we're somewhere in the middle, where we say, we kind of want to make a good decision based on the likelihood of him getting better, one, the likelihood of him getting through the surgery with no
There he
problems,
goes.
and thirdly, sort of avoiding complications along the way.
Yeah.
Well, that's exactly how it gets complicated, and that gray zone is it's hard to answer questions and give
Yeah.
you exact things. If you ask me what I recommend, my opinion, and it's just my opinion,
Yeah, your
it's not my
opinion.
boss's opinion or anybody else, is that these are fairly well tolerated. They do come out. They are fraught with some kinds of problems. Sometimes when they come out and we get into these areas here that I was telling you about, they can cause trouble down the way. Now, what does that mean? Does that mean 3 months down the way versus a couple days? Usually, it means it declares itself while they're in the hospital. A lot of times, though, we're able to fix it, first go. But it's of course all those unpredictables that we run into that make our job difficult. That doesn't mean that it should sway you one way or another. It just means that they are hard to predict with regard to how much trouble we'll run into. So I know you've asked me sort of for a direction, and I've given you nothing. Probably, I understand.
If so, it was your dad.
Yeah. Well, the way that I like to answer that, though, is it's not. In terms of you have to make the best decision for
Yeah.
your family member.
Yeah.
And that's the challenge. Is it's not that I'm avoiding the question. It's that it's not easy.
Yeah.
What I can offer is that, like I said, the surgery itself tends to be tolerated well. It's about an hour to 2 hours, and not very long. He does have some comorbidities. We'd want the medicine team to probably look at him and make sure that he's okay to go to surgery if we do it in an elective fashion. In other words, if something happened where his condition changed, and we may have to accelerate the pace of going to the operating room, that's the reason why I wanted to even entertain the discussion, is because those intangible things that I can't predict is something that I wanted to get addressed. I guess is what I'm saying.
How much of this is the insurance going to pay for?
I have no idea. I wouldn't worry about that at all, though.
Okay.
Only because, in my opinion, that's neither here nor there.
Okay.
You know,
I know my mom's going to ask me.
I know exactly where you're coming from, and it's not. It's not that I'm trying to belittle the concern, because it's valid.
Yeah.
It's just that in terms of fixing him and getting him help, it's not a concern that I
Okay.
have.
All right. Then we're going to talk to my mom.
Sure. Yeah.
And see what she's thinking. And
Okay. Let's do this then. I have to run upstairs and see a patient.
Right.
Take your time.
Okay.
Talk it over.
Okay.
And I'll be there. Questions are going to come up, so
Right.
just either jot them down or remember them, and I'll be available to answer them.
Okay.
Okay.
Oh,
Sure.
Great.
A lot of this is coming at you all at once, so I
Right.
understand it's a lot to be handling
Yeah.
all at once.
Yeah.
So,
So, thank you very much.
sure, no problem.